Welcome to COP TV, Communities of Practice Television, in the Department of Family and Community Medicine at Meharry Medical College. Today's episode features Dr. Earl Stewart Jr. on the necessity of training medical, dental, and public health students to be on the front line of reducing and eliminating the opioid crisis. You can visit COP TV for the remaining episodes.
Teaching the importance of setting expectations with patients, teaching the importance of understanding that we do not prescribe opiates for all kinds of pain. I didn't go very much into this, but there really aren't much stipulations placed on prescribing opioids for patients with acute pain. So say, for instance, a patient has surgery, they're going to usually need opioids. Say, for instance, a patient has, some sort of orthopedic surgery, or they fall and they break a hip. Of course, that's an indication for pain, but you try to almost always focus on, in every situation, non-opioid therapies first. And if that does not really control a patient's pain in certain situations, then you can prescribe opiates. But the stipulations in terms of prescribing these medications is not, does not really relate very much to, hospice patients, surgical patients, patients who are hospitalized. But it is extremely important that our students understand that early on, because that's where we begin to formulate our thoughts about prescribing medicines. That's where we learn pharmacy. But a lot of times we don't get, sometimes we don't even get that in residency. So a lot of times people have to do fellowships in addiction medicine to really understand the importance of prescribing practices for opioids. So it's important even at the level of Meharry Medical College, even at the level of Morehouse and Emory University School of Medicine and all these other very great institutions of medical training. We have to be taught that early. I think that's where it's going to really formulate within a physician's mind, hey, and I say this all the time, I remember probably counting on one hand the number of times I prescribed an opioid in residency. Brown just beat it into us. It's just like, why do you want to prescribe it? You have to have some sort of rationale and understanding to be able to articulate why you need it. And so when I moved, and I'm not speaking bad about my practice by any means, but when I got there and I saw that, some of my colleagues were giving like 90 and 120 hydrocodone to 40-year-olds. They looked at me like I was crazy, but I looked at them like they were crazy. I'm like, what are we doing? And some of our more seasoned physicians, they've been practicing a certain way. They understand that it may not necessarily be right based on, updated guidelines, because we have to check the Prescription Drug Monitoring Program database, or else you're going to get fined by the state if you don't. And that went into effect in July of this year. They understand the importance of doing all these things, but still, they want the patient to be, happy. They want the patient to be satisfied. Well, sometimes, that can really hinge on doing something that's not in the patient's best interest. So I think that's where a lot of our practices and our teaching has to change. You have to tell patients, hey, you want Percocet and you want hydrocodone, but consider the fact that this might do you some harm. You focus on it in one way, saying, I just want to be pain-free. Well, you're not going to be 100% pain-free 100% of the time. And so one of the things that we often learned in my residency is that set expectations with patients. Tell them, hey, you got chronic pain. At what percentage of time will you be comfortable with being pain-free? 60%, 80%, 90%, 75%. You'd be surprised what patients will say. Some will say, well, if I'm okay if I'm pain free 65% of the time. Let's develop a plan. Let's do this for pain 1 to 5 out of 10. Let's do this for pain that you rate, subjectively as being, 6 to 7 out of 10. And then let's do this for severe pain 8 or higher out of 10. That really is the appropriate way, and trying to focus first on non-opioid based therapies. There was an attending of mine, I'll say this and be quiet. There's an attending of mine who took hydromorphone Dilaudid completely out of his practice when I was in residency. He would not prescribe it to anybody. And what you see now, even in communities like Thomaston, our orthopedic surgeons, if they do surgery on somebody, they won't give them anything for pain after they do the surgery. When they're discharged to rehab, they won't prescribe an opioid. They'll tell them to take Tylenol, and that may be in their guidelines that they follow. They'll tell them to take Tylenol or do ibuprofen, if they can tolerate it, of course, based on their medical history. And then, you got one orthopedic doc who's beloved but very blunt. He'll tell patients that you're not getting it from here, so you might as well go somewhere else. We're not that brash at our practice, but we understand the importance of setting expectations early on. There are certain patients who I identify when I see that they've checked in, and I look them up in the database and I see what they're here for, and when the nurses send me the charts, and I walk in, I tell them, I'm like, I see you went to so-and-so and so doctor. If you're looking for pain medicines, we're not doing that. I would be happy to refer you to a pain specialist, but we're not doing that. And if you feel like that you have an addiction to opioids, I'm willing to, discuss with you alternative options to help you deal with that addiction, namely Suboxone, buprenorphine derivatives. You have some patients who never come back after that. You have some patients who come back and say, I have a problem. And that happened earlier this week. A young guy who was struggling with it came back and said, I think I'm ready to be on, Suboxone. I think it would be helpful for me because I'm 20-something years old, and I've been on Percocet, from different doctors, and then they stopped giving it to me, and I've been having to get it off the street. That's what we're seeing. That's a classic patient we're dealing with. So the goal is to help them. That's all we try to do.